Hi, everybody. This is Lori Atkins. Welcome back to the Happy Nipple podcast. I am so glad to present episode number 3 with Catharine McDonald of Growing Well Counseling here in Connecticut. And this is a huge topic, and I'm really excited to explore this because if you work with women and families at all, you know mental health is a huge thing, and pandemic times has even made it more of an important topic to discuss. Perinatal means around birth time, and perinatal mental health spans preconception, as you'll hear Catharine talk, to months after your baby. And it isn't just depression, it's lots of things. And that's why we called this episode Under Pressure. Lots to discuss and unpack, and I'm glad you're along for the ride with us. But here we go with our NIP tip of the week. So our NIP tip of the week is about breastfeeding being thought about as all or nothing. And I deal with families all the time in my practice who, for some reason or another, are supplementing their own breast milk for their babies. Either breastfeeding isn't going as they planned, or there were interruptions to breastfeeding, or there are physical or emotional reasons why breast milk production isn't where it could be. And sometimes there's discussion about supplementation. And so immediately people think supplementation for or with formula, especially pediatrician's office. They'll start to say, well, you have to give formula, and this is how much you have to give, 2 ounces after every breastfeed, blah, blah. And so first of all, my thoughts on this are supplementation doesn't have to be formula. It can be your own milk. If you're able to pump and supplement with your own milk, calories in breast milk can be much greater than calories in formula. Yes, that's true. Formula is a static substance. It never changes. It's about the same calorie every single time you feed your baby, but breast milk can be anywhere from 20 calories to 27 calories, it's been discovered to be. So it can change according to the feeding, and does change all day during the day. So my point in telling you is this: it's okay if you need to supplement your baby. You can also use human donor milk, which we're going to get into. We're going to have another podcast episode on donor milk, which will be very exciting. But you can supplement with your own milk. You can supplement with donor milk. You can supplement with formula if you need to. And it's okay if you need to. I want you to hear me say that. It's important. I think the idea and the thought of exclusive breastfeeding has been drilled into our psyche. And I think it's really hard for parents who need to supplement with some other substance or some other way for their baby. And it just defeats them in such a deep way. And it doesn't need to. Some early supplementation with some, in some way, or with donor or formula milk, it doesn't mean your breastfeeding is for naught. And it doesn't mean that it's going to go away. And it doesn't mean that it's not going to work. The supplementation that you need to do for your baby does not denigrate the breastfeeding that you're doing for your baby, and it doesn't need to be all or nothing. So that's the message I want you to hear on my NIP tip of the week. I know it was a little broader this week, but that's a thought I've been having lately, and I have made the point on social media lots of times that breast milk is not all or nothing. So with that said, let's go on to our discussion with Catharine McDonald of Growing Well Counseling. Thanks so much for coming along. Good morning, my dear Catharine. How are you?
Good morning. Thanks for having me here. I'm good. It's so nice to be with you this morning.
It is so nice to be with you on a rainy Saturday morning. And I was just joking with Catharine, you're getting me in my cozy today because I just didn't feel it. And, you know, new families, sometimes
it's a cozy kind of day.
It kind of is. It's not cold, but it's cozy. So this is what you're all getting. And look, Catharine shows up in her very nice professional office. So I feel a little like I'm letting her down.
Not at all.
Welcome. You are, I can't even think of the number now, but welcome to the Happy Nipple podcast, Catharine. I'm glad to have you. So this is Catharine McDonald. I'll let her share her credentials, but she's one of my favorite people. She's one of the best perinatal therapists in the land. And in all actuality, I wanted to share with people, you were going to be my first podcast host. You remember we talked about this years ago.
Yes.
And because Catharine is just so dang busy, this is what we could manage on a Saturday morning to get together. So I am glad you're here. Glad to have you. And because we see so many issues with perinatal mental health, perinatal meaning around the pregnancy. And I'm going to let you get into that a little bit more about what you do and how to find people like you, because that's going to be our goal at the end of this, is to really, my goal in all of the podcast episodes is to connect resources, is people to what they need, and no matter where they live. So we'll get into that. But welcome, and tell my audience a little bit more about you, Catherine.
Thanks, Lori. I am a licensed professional counselor here in Connecticut, and I am the owner of Growing Well Counseling, exclusively devoted to helping perinatal wellness and families grow well, whatever that means for you. So that might mean making decisions about family planning, experiencing fertility challenges or loss, going through a pregnancy and then planning ahead for the postpartum, and then experiencing any sort of postpartum emotional complications, stressors, or proactively wanting to reduce postpartum stress and help the whole family grow in a healthy way. Growing people is really hard and often much more complicated than we think it'll be.
Can I stop you for a second? Growing people is really hard.
It is very hard.
That is, you always say little isms that I love. That's got to be another favorite of mine. Growing people is hard work. Wow.
Isn't it? It is a lot of work to grow a whole person.
Yes, absolutely.
Yeah. And then you have to birth them. And then you have to take care of them and keep them alive, which and help them adapt to all the people in your house. Or
no big deal.
It's a lot. Even when things go perfectly, smoothly, no known complications, it's still a really big journey. And so many things are really unique to the perinatal period. And when I say perinatal, I'm thinking about conception through pregnancy, birth, the postpartum. And the world of perinatal mental health, as kind of Postpartum Support International, is really a guiding body professionally and I think personally, in just terms of normalizing perinatal emotional complications and really expanding the definition of perinatal. The DSM, the diagnostic manual that we pull our diagnostic codes from for insurance purposes to help get insurance coverage, is largely driven by white men who didn't do a lot of parenting. And they talk about the first 6 weeks postpartum, like everything magically gets better.
Of course.
It's easy one, right?
Pop up, you can do a marathon, 6 weeks, no big deal.
Right. If that, and we think about the reality of the first year. And I even urge people to think about beyond that. That's really like where we want to see you on an upward trend, but you can be a year and a half out and still be replenishing nutrient stores that were depleted from a pregnancy.
Oh my gosh, yes.
With an ideal diet and good supplements and good support. So often it can take upwards of 2 years to get fully back to yourself, finding that new self and feeling a sustained wellness. I have a lot of clinical mental health training, but I really like to spin that focus and use language in my therapy work that's empowering and really wellness focused, meaning not looking for surviving, but finding a place of sustainable thriving, which has looked really different in COVID. I think that it's so important to acknowledge that the past 2 years have been in no way normal for family planning, prenatal care, and building that support network postpartum has looked really different.
Right. Do you remember the conversations we had in COVID that you joined me on a support group once, and you said something to me that I will never forget. I want to tell you this. You said to me, no one is okay right now. Yeah. And it stopped me because I was so focused on turning my business into a model that people could still find me for breastfeeding care. How the hell do you do that when we were locking down? And I think we were all scrambling. Everybody who's listening to this knows what I'm talking about. We all pivoted and scrambled. And in my scramble, I was so focused on getting everybody else taken care of that it kind of made me look at myself a little bit and say, ooh, what's going on with you? Because you're so focused on the mamas, what's going on? So that, and then the other thing you said is give yourself and everyone else a little grace right now. Do you remember that? I don't know if you remember it, but it was so telling it. I have used those words in my care of families in the last 2 years and seen the effect of those few words. Give yourself some grace. Because we give everybody else some grace, or we try to, we should, and we never do it for ourselves. So I couldn't wait to share that with you this morning, because I wanted you to hear that that really made a difference. And it was a crazy time. It still kind of is. And I know that
still don't feel very normal.
I
And
can,
I know that so many of my families have an ongoing justified anxiety with unknowns about what COVID will look like throughout their pregnancy, at delivery, fear of having COVID at delivery, not knowing if partners will be there for important results being given, important tests, ultrasounds, and also the fears of what working and living in COVID, well, it's still, the positivity rate is still kind of fluctuating. We don't,
it is.
and
There's something,
we're still learning.
We're still learning. And the science is going along with us, which is interesting. Usually we have science that's ahead and that can report back. But now it's like the science is neck and neck with what's actually happening. So it's hard for people to get a grip about what it's going to look like. Is there another variant? I mean,
and I think that's another burden on parents and expectant people, because you'd want to rely on the science. I love referring to evidence-based resources and giving moms solid information that they can trust, or directing them to those appropriate resources as a means of anxiety management and resource management, helping them make those informed decisions. And it's really difficult and unsettling to be doing that as the science is evolving. And it doesn't feel good as a therapist to not have a solid, confident resource. It's, oh yeah, we know that. I can direct you to the appropriate place for that.
Yeah.
So some of my work has shifted from giving resources to sitting with the uncertainty with clients.
Sitting with the uncertainty. That's another thing to think about, sitting with that, and how does that feel and what does that mean to you, right?
Yeah, it's a doozy when you combine that with a type A personality and a selfless mom who just wants to take care of her baby in the right way.
Or somebody who has kind of a really traumatic history or a really traumatic birth or issues in their pregnancy. So you kind of see everybody, and are people coming into their pregnancy with a lot of, I hate to say the word baggage, but in a gentle way to say history and things that kind of happen.
From a developmental perspective, anticipation of the next generation, of bringing a child into the world and transitioning into the identity of a parent, is a really natural time to reflect on your own childhood, thinking ahead to the things you are going to repeat and the things you don't want to bring into that or pass on to that next generation. And it often leads to a lot of clients thinking about their own mothering and ways unfortunately, their parents may have let them down, things that they wish they had. And sometimes that's in the present also, that I know that postpartum is going to be hard and I can't count on my parent to support me in the way that it would be nice to, or, mom never talked about feelings. So I know I can't talk to her about my worries or ask her about her feelings postpartum or around birth. And so there's some developmental stuff that naturally is going to come out. And then it's a big existential shift to be thinking about your most important person. I've got to take care of myself, to now my most important focus is this baby. And it's a lot of pressure to do a good job taking care of a baby and raising them and in the way that you want to or hope to, and keeping them safe and making sure they're thriving. And then a lot of people have past traumas that are going to resurface. Prenatal care is very vulnerable, even with the most respectful provider. It's a vulnerable experience and sometimes brings up some familiar sensations from unpleasant memories in the past. And then there's a feeling of loss of control. You can choose to not prevent pregnancy, or you can choose to initiate pregnancy medically. But then there's this sort of facade of control where you're like, okay, well, I have to do a good job of being pregnant. Right? Don't eat the bologna, don't eat the sushi. The don't list is pretty long. And we put this false sense of control on women as a society. And really, you can't control if the egg is going to fertilize or not. You can't control where the placenta attaches to the uterine wall. You can't control if a subchorionic hemorrhage comes up. And you also can't control if your uterus isn't going to keep that baby inside as long as you like. And then there's the feelings and sensations in a biologically normal pregnancy of baby moving inside that can be unsettling or startling, and anticipation of birth can be really difficult with the unknowns, with our society loving to make it such a scary thing.
Control with that. It's a big deal because there's so much, that's a big blank slate, right? I mean, for thinking about what's going to happen with my delivery, ...
And wanting people to know the resources that they can put into place to help them feel safe, to reduce vulnerability. It's a vulnerable experience, period, but you deserve to feel safe and respected in that experience and have a voice in your care, not show up and have things be done to you. And so I do a lot of preparation. I see a lot of clients who've had a traumatic birth and want better next time. And we talk about avoidable, when I teach about birth trauma, I talk about avoidable and unavoidable traumas. And there are some things that nobody could have helped that they happened, but we can talk about how they were handled or processed or debriefed afterward. And then there are things that really shouldn't happen in American maternity care that come up, unfortunately, too often. And how women are treated in birth matters, and it impacts how they're feeling postpartum. And are they going home feeling broken and violated, and then covered, leaking milk and bleeding, recovering and trying to care for a baby and sort out what just happened to me. And then there's postpartum depression and anxiety that can creep up, and that's a tough combination if the birth experience didn't go well. And then sometimes conversely, it's difficult. So somebody could have had a positive birth experience, and then that leads them to be shameful of themselves. I had a good birth. I got what I wanted. Why don't I feel well? What's wrong with me?
Right. I should be grateful. Things worked out really well. They told me to be happy. Yeah. So we talk about postpartum depression, and I think that's what everyone thinks about. They think about, if you're old enough like I am to think about Brooke Shields, the wrote her book, where in the 80s, 90s.
Down Comes the Rain.
Yeah. So there's a bunch of celebrities that have been talking about postpartum depression. And I think that even sometimes when I talk to partners, those are the terms that they use. So I think that people think about just depression. And so when I sometimes talk to them about anxiety and OCD symptoms that can come after birth. So can you tell us a little bit about why we've needed to expand that?
Yeah.
It's not postpartum just depression. It's postpartum lots of things that can kind of pop up and be symptomatic. I think I want people to kind of hear this about things that they can it's not just sad or throwing the baby out the window. It's lots of other things.
You went right there. Out the window.
I'll be throwing the baby out the window. I'm glad you did. Girl,
nobody's throwing the baby
psychosis. I've been a nurse a long time. I've seen it a few times in my career, but not as much as people think.
Right. So, and I think because of mental health stigma and lack of education in the general community, no high school health class is doing this justice.
Ooh, that's a good point.
We don't know a difference. Everybody who's not feeling well could be psychotic is how some people feel, or something's wrong with me. I must be a threat to myself or my baby.
Right.
Postpartum Support International recognizes not just postpartum depression. They have an umbrella term, perinatal or peripartum.
Can I stop you for a second? Can you explain what Postpartum International is? There could be people that don't know what that is.
That's a good question. Postpartum Support International is an international nonprofit devoted to creating supports and education and resources for people growing people is the broad term I'm going to use, because it is the name is postpartum, but they do so much prenatally. One of the really important things they do is they have a free consultation line for prescribers. Many women who are well or maintain their wellness on medication are inappropriately taken off of medication, or they're given misinformation that it's dangerous. A mom who's not well isn't good for a baby. And it's not fair to talk about the risks of medication without the risks of an unmedicated, unwell person. Because the reality is, if you're talking medication, the mental health issue is already there. Right. So you risk, when you don't treat a mental health issue, you risk exposure to elevated cortisol, to a mom who's not taking care of herself, to inadequate nutrition, to inconsistent prenatal care, and the list goes on. And there are observed researched effects on increased risk of preeclampsia and preterm birth. Systemic inflammation is inflammation.
Right.
We can reduce that and really help women. And there are many drugs that have a lot of research. Nobody is going to commit and say they're safe for pregnancy, but nobody will commit and say Tylenol is safe for pregnancy.
Exactly. And so we deal with this in breastfeeding all the time.
Critical.
About medications for mental health. And almost all of them are safe with breastfeeding. Again, I'm not going to commit and say every single one, because there could be one outlier that really we have to watch. But we know Zoloft especially has been around forever and has been studied forever in breastfeeding.
And I like to reassure moms that we don't lack research on high schoolers and beyond. because we were able to follow children who were exposed in utero and via lactation into elementary school. And we're like, okay, at what point do enough standardized tests and emotional assessments tell us that they're doing great?
That it's
And
okay.
really, the children that have moms who got their depression or anxiety treated are the ones who are doing best. And
Right.
moms really worry about passing this on. And that's, I could talk
It's
a whole
bit,
podcast.
right. It's a larger picture than just the medication. That's
So
a great.
one of the huge things that PSI, Postpartum Support International, does is they have a perinatal psychiatry consult line where an OBGYN, midwife, a psychiatrist, anybody can call and say, I have a patient, these are their symptoms, they're in the first trimester, and they can speak to a reproductive psychiatrist at length and get guidance.
Wow. I had no idea.
So amazing.
That's
so
awesome.
that's an important thing to do.
Yeah.
They have a ton of support groups for all sorts of special, unique circumstances. They have groups for dads. They have groups for different languages. They have groups for loss. They have groups for termination for medical reasons, because any pregnancy, exposure to a pregnancy, to the hormones of pregnancy, the nutrient depletion of pregnancy, and then the social experience of being pregnant and potentially no longer being pregnant can all impact mood, and they're unique, different groups. So they have a ton of free support groups, a warm line where volunteers around mostly in the US, but there are some international volunteers who will respond to messages and offer support to moms, which is great complement, not replacement for psychotherapy. And they even have text support. So mom is feeling stressed and just wants someone to chat with, and there are volunteers who respond to that. And then they offer professional training for licensed mental health providers. They have some peer support providers. I see a lot of doulas becoming peer support providers and really expanding their expertise to support the whole person.
Right.
Because a person growing a human is so much more than just a uterus. There's a whole person attached.
It's a whole person attached to that uterus. Yeah.
So at a Postpartum Support International conference, which I've had the benefit of attending and presenting at a few, there you'll find doulas, lactation consultants, therapists, prescribers, OBGYNs, and midwives. It's an incredible interdisciplinary collaboration. And they provide what is considered internationally as the foundational training for mental health therapists. And it is so critical because of one of the perinatal mood disorders in particular, that people are appropriately trained. My graduate program was over 80 credits. I had a lab practicum in every single course. It was pretty rigorous. Not a word about perinatal mood and anxiety disorders.
Really? So all of your education has been post-grad?
I've accumulated over 200 hours of postgraduate training at this point, and I'm still learning. Right? There's so you're always learning, right? Yeah. But it is so critical to have at least that foundational training, in part because the term perinatal mood and anxiety disorders, little stuffy, but it's an umbrella, encompasses postpartum depression, postpartum anxiety, postpartum bipolar disorder, OCD, PTSD, and psychosis. So these are each unique and distinct from each other, as well as from general adult mental health concerns. For a couple of reasons: the hormonal and biological effects of a pregnancy, and potentially lactation, because until we are lactating, we don't know how prolactin influences hormones and our mood.
True.
The nutrient depletion, I think, is huge, because you are, until you have a first pregnancy, you're building up vitamin and nutrient stores, your zinc, your selenium, the things you don't think about, right? And then as soon as you're pregnant, your body just starts donating that. Just give that to the baby, and you get what's left over. And I liken it to New England before a snowstorm. There's like one crushed loaf of bread in the back of the shelf left. And that's what mom gets, right? Baby took all the bread, all the eggs, and all the milk, right?
And you're getting that.
Just getting on French toast, right? Yeah.
Good analogy. I'm an analogy fan. Yeah.
It takes a while to restock those shelves.
Yeah.
And that's going to affect your mood, because anemia, vitamin D depletion, vitamin B depletion all contribute to mood. So there's the unique nutritional and nutrient deficiency stuff that goes along with a pregnancy. And then there's a human. You're operating unnecessary sleep deprivation, and you've got hormonal changes and existential changes. And when I say existential, that you can't bring in another human into the world that's yours, that you love more than anything, and that changes your identity forever, and not have it stir things up. So there's this change of the meaning of life and what your priorities are that's going on. the logistics, navigating co-parenting potentially with a partner, and then just the needs, the incessant needs of a baby, because humans give birth to really needy offspring.
We do.
That are less developed than many other mammals. So you can't just say, you know what, baby, I need a good night's sleep. Like I need a good 12 hours to get some progress on my mental health, because baby needs to eat every 2 to 3 hours. So there's a multitude of those factors. And then also the psychological focus on the baby can cause distress. With postpartum anxiety, I see a lot of women worried about the baby, obsessively so at times. And anxiety, OCD is an anxiety disorder. Obsessive compulsive disorder is an anxiety focused disorder much of the time. And what kind of sets it apart is their obsessive, repetitive thoughts you can't get out of your head. And many times there's sort of this false sense of comfort. If I just do this repetitive motion, or if I just do things a certain way, a compulsion, it'll temporarily relieve it. But really, it just kind of fuels it, right?
It fuels that, right?
So then there's bipolar disorder, which is very commonly, a peripartum bipolar disorder is disproportionately common in women who already had a bipolar disorder. The stress and the hormones of a pregnancy are going to kind of nudge up the ante on a bipolar disorder, which is why it's critical to stay on medication. Baby and mom will benefit from keeping a pre-existing bipolar disorder steady. Occasionally, really, really rare, somebody hasn't had an episode of bipolar disorder, but there's often a genetic predisposition. So it's even more rare. If you don't have a first degree parent or sibling with bipolar disorder and you don't have bipolar disorder, it's really unlikely that's going to happen. And I think that's important to say, because it's scary. Bipolar disorder sounds big and scary, but it is not something that comes up run of the mill nearly as often as it can feel like when you have anxiety and you're worried that you're not mentally well.
Right.
PTSD can be pre-existing trauma reignited by a pregnancy or delivery. A disproportionate number of women, way too many people in the US and in the world, are survivors of assault of some sort.
Sure.
And the vulnerability and sensations of pregnancy and delivery and sometimes sensations of lactation and someone touching your breast can be really triggering. And then birth can be triggering. Over a third of women experience trauma in their birth. That doesn't necessarily meet qualifiers for PTSD, but if you fear or perceive your life or your baby's life to be threatened or at risk in that moment, it can become a traumatic stress disorder.
Right.
So it can be pre-existing or in the moment trauma. And then psychosis is very rare. I think it's so important to highlight how rare this is. It does occur more often with people with a pre-existing severe persistent mental health condition like a schizophrenia, schizoaffective disorder, or a bipolar disorder.
Okay.
So the number 1 in 1,000 women is really even smaller than that for someone who does not have a significant pre-existing mental health condition.
Right.
But so many women who have postpartum anxiety or OCD are fearful that they have postpartum psychosis, that they want to hurt their baby, they want to throw their baby out the window. And this is why it is so, so important, can't stress this enough, to go to get help from a trained provider, because 2 to 3 times a year, I get a client with horrible anxiety in my office who has been traumatized by the medical system, went to a general therapist, told their pediatrician or their OB, I'm having these thoughts about my baby falling down the stairs, or I try to be very mindful about examples because I don't want to add to someone's anxiety, but we all know those thoughts.
Right.
The reality in the perinatal world is that, over 80% of women have unwanted intrusive thoughts.
Right.
The unwanted is key, because the person with psychosis does not think there's anything abnormal with these thoughts, these dark or scary unwanted thoughts. They're not unwanted. They're their normal thought. Like, I got to go to Big Y later. It's not distressing to them. So when I talk to clients who might have, I always ask about intrusive thoughts. And then I want to assess and feel like, well, how upsetting is that to you? And often I hear things, I'm disgusted, I'm terrified, and I see a lot of protective behaviors, right?
Right.
That's reassuring. And this is the unique instance in which distress is super comforting to me. I'm like, go ahead, tell me how upset you are.
Right. If you're upset about how you're feeling, then clearly you're in
Right.
control of your thoughts. And it's not, so
Right.
psychosis is more moving beyond any
Psychosis is a
rational
break
thought.
with reality.
Right. It's not
And
right.
it's a loss of reality. And then there's often the presence of auditory or visual hallucinations, delusions. They often commonly have a religious connotation. So there's a thought of a relationship with the devil or with God. And it's pretty intense and extreme
It's not
much of the time.
hard to miss. I think that's another thing to kind of.
It is.
People.
It is. What's interesting about that is it can be really, it's significant, but you gotta talk to the mom, because women in the postpartum can what's called wax and wane. They can have moments where they're more clear, but then you might catch them talking about God wanting them to do this, or God was talking to the baby the other day. And it's a delicate balance also to honor cultural traditions and knowledge and faith-based focuses or relationships without pathologizing them.
Right.
Again, why it's so critical to have a specialist. And unfortunately, I've had so many people sent to the ER, separated from their baby, reported to DCF.
Yes.
Because somebody hears this thought, I thought about throwing my baby out the window the other day and I felt disgusted. And that person is cowering on the inside of every room. They're not going near the window. Right. They've moved the furniture to the other wall.
They're not right. They're not going to act.
Extreme and unrealistic lengths, right, to protect the baby.
Right.
So the more distressed the mom is, the more reassured I am. When somebody doesn't have that knowledge and training, as a therapist, it could be really scary to be like, oh my goodness, this mom said what
do I do with this? Is she safe? Is she not safe? So do you think that people just kind of go, oh, I'm going to be really careful and send this mom to the ER? Because as a lactation consultant, I worked at a large hospital for a number of years and did lots of visits to the emergency room, to the psych area, more than a few. And I never realized how horrific that can be for a new parent. And you are talking about, I'm thinking about one specific instance in my mind that the mom shared intrusive thoughts. She had no other concerning, she just she saw herself running into a tree in the car.
Yeah.
She goes, I didn't want to do it, but I saw the tree. Every time I passed it in the car, I saw myself hitting it, but I didn't. I didn't want to. And it was like, that didn't seem, but they put her in the ER, away from her baby for about 8 hours.
And I've worked in the ER. And the reality is that when you have a meek, tearful, terrified mom, she can't be a priority to somebody who's on drugs and violent or volatile, who's screaming, to a child with a psychiatric emergency. She's going to be there a long time. And I've had clients who are still bleeding, who can't appropriately care for their healing bodies. I've had women who get mastitis or engorged because they can't pump, and nobody's thinking about the whole body. They're thinking about the presenting concern, which is their job. The ER is supposed to look at the presenting concern, address it, and move on. That is not an ideal place for pregnant or postpartum people. And I can appreciate the caution that some of the healthcare providers who don't know better take, but we've got to think about what's the reality of what's going to happen. And we need to be informed about that. If a pediatrician is going to screen for intrusive thoughts, they need to know what to do with them.
That's a really good point. I have my good points, and I find that's a really good point. If you're going to talk about it with someone, you better know what you're going to do with them if they present that way. And how can you support them in the best way?
And there are some pediatric practices in this state that do a phenomenal job. That they want to screen. They recognize that the many early postpartum visits for baby, those new baby appointments, are a prime opportunity to check in on the whole family, which really benefits their patient, because then we know that everybody is well and capable of giving baby the best care possible. But then they know what to do with it. And I love when I get a referral from a pediatric practice, because we're all going to work together to help the family be well.
Right. This is a really, really good point to make. Tell me a little bit about how lactation kind of folds into what you do. Do you get,
I love to refer people to you prenatally.
I love prenatal.
I think a pregnant person is such a great opportunity to influence outcomes. Influence, not control. It's not my pregnancy, it's not my postpartum, but there's so much I can do. When I get a pregnant person in my office who has a history of or worry about a family history of anxiety or depression, there's so many things we can put into place. And I have undergraduate background in family studies, and we did a lot of resource management, and I pull from that a lot, thinking about how to resource the family to help them be set up for success. And so around the 28-ish week mark, I think when they're talking about their glucose screening is a nice time to start thinking about the postpartum, and we have time to plan. So I have a 5-page postpartum plan I go through with clients. The doula or the childbirth educator, or hopefully the OBGYN and midwife, are going to be asking about a birth plan. And I kind of nudge them. I'm like, you don't have a birth plan. Now's a good time to start researching that stuff. Going in with a plan helps you feel empowered and less out of control. So it's super powerful for mental health. Mm-hmm. The postpartum plan looks at what are the resources that are going to be helpful to you in the postpartum. And I have a page about baby care. How do you want to care for the baby? Where do you want the baby to sleep? How do you want to feed your baby? And I try to be really open-minded and non-judgmental, and I want to be one of the first voices about feeding that just kind of breaks any assumptions. I like to say there are so many ways to feed a baby.
There are.
Our society is really black and white, and people might say, are you breastfeeding or bottle feeding?
Oh, all the time.
Are you breastfeeding or formula feeding? And I say, are you going to do you want to feed your baby breast milk? And if so, how do you want to do that? Do you think you might want to feed your baby a combination of formula and breast milk, and be really find the Switzerland, right? The neutral territory.
Right.
And if there's any interest in making milk, I think a lactation consult and breastfeeding class is a great way to just eliminate some problems from ever occurring. Mm-hmm. And I also think that relationship building is key. So I'll recommend, call Lori, let her know how pregnant you are, when you're due. And then I stay in my lane. And I'm like, I want to make that connection. And then you do your magic. And then in postpartum, when they're leaking milk or their baby's yelling at them and they're like, is that hungry yelling at me? Or what is this yelling at me, little person?
Kind of yelling.
Then it's much more comfortable to call you, because you're not some number I gave them 5 months ago, but you're Lori, you're who did my prenatal consult, and you know me, and you know my baby, and you know my due date, and you know that I'm probably going to be calling you this week. And it makes it safer and more comfortable to call.
So prenatal visits for me are super empowering as well, because when I do a prenatal with someone, I did the big classes for years, and there's nothing wrong with that. Let me put that out there for people who are going to go back to attending in person. But one of the tiny silver linings of COVID has been that our prenatal work for me has been brought to either a virtual forefront or just individual couples or individual families together. And then I can get to know them a little bit better. And then they feel comfortable talking to me about their mental health history, or I had a really traumatic birth experience. This is how I want to change things. So we've kind of brought it to this PowerPoint, large auditorium, pointing at the PowerPoint, trying to stay awake on a Monday night, to a really intimate, personal setting that I know that I can get to know my clients a little bit better. And if they have a history of mental health challenges, it's really good to know that up front and ahead of time, because then we can I can say to them, what's your team? And when we talked to the doulas on the podcast too, it was like, who's in your postpartum team? And it doesn't have to be somebody you pay. And that came up the other day. Somebody said to me, if I could afford a doula, I would have one. And my heart broke. I was like, oh, I know that I can't fix all the problems in the postpartum world, but it could be your mother-in-law and your friend and your neighbor, right? It can be people that can help. And tell me a little bit about creating that scenario for your clients about how to get ready after.
Yeah. So I'm talking about the transition through that postpartum plan. I devote a whole session to it. It's a solid hour of us initially creating like your first thoughts, and then go back to your partner if you're partnered and discuss with them, and then come back to me and I'll fill in any resources where you thought, oh, we could use some more information about that. So we're talking about, do I need information? Because a great way to ignite some anxiety is to not know what's going on, to fear things are being done to me. Can I make an informed decision here? So whether it's about lactation, about childbirth, about C-sections, epidurals, whatever the topic might be, like, I don't know enough about that.
I need to get more info.
Knowing what to expect.
Yeah.
Then planning ahead, trying to make the postpartum as simple as possible. So I encourage families who are financially able to start stocking up on things, like reduce the stuff you need to run out for in those first few weeks.
Oh, that's good.
So that does a few things. It takes off financial burden on an unpaid leave. If you can rearrange your, stock up on dish soap, laundry detergent, paper goods. And then also whether it's partner or a mother-in-law or a friend, say, can I grab you anything from Big Y? Can you just get us some fresh produce and some milk? It makes the immediate shopping list easier in the moment.
Grocery shopping. Yep.
And it gives you less to run out for. It just makes life a little simpler. Planning ahead, contacting HR about how much leave you will have and how that's covered. And well, I was initially cautiously hopeful about this Paid Family Leave Act. It seems like a lot of my clients are having trouble navigating the new Connecticut Paid Family Leave.
Yes,
So
I agree with that. And I have yet to see anybody who's gotten paid, actually money in the bank.
Same. So knowing that and getting on HR if you're hoping to get paid leave as early as possible, and then planning accordingly.
Right.
That's empowering. So mom doesn't feel like she's being torn or needing to rush back to work before she's physically and emotionally able. We talk about, what do you want for your birth? What do you need to talk to your OB or midwife about? How are you going to nourish yourself postpartum? What supplements are you on right now? And let's get a couple extra of those in the pantry so that you're not running out of them, right? Making sure that women are aware that it would be worthwhile mentioning to you what supplements they're on, so we can plan ahead and make sure they're getting enough of the important nutrients to compensate for the depletion of lactation. And I say, breast milk is really valuable, but it takes from you.
Sure.
So you're going to have to keep
from your bones.
Keep up the increased intake so that you get some, because you get what's left over.
You get the squished bread in the back of the class.
Yep. You get what's left over. So that one little sad loaf of bread in the back. And so I talk about supplements, and then I encourage them to talk to their doctor or midwife. And I also I try to educate about scope of practice and expertise. And oftentimes a naturopath is really valuable to consult with about high quality bioavailable supplements, supplements that are safe for nursing, and things that are going to allow a mom to rebuild and to get what she needs and rebuild the depletion from a pregnancy, which impacts mental health.
Absolutely.
So we talk about that. Are there any resources that you need? And when we talk about professional and peer resources. So if you have any thoughts of making milk, a lactation consultant is worthwhile. And I talk about the different kinds of lactation consultants. So a hospital lactation consultant, as you know, the bulk of their work is the early days postpartum.
It is. Yeah.
They probably don't see a lot of 8-month-olds. They probably don't see a lot of teething babies.
No.
And in private practice like you're going to get a much broader scope. So you've got a quantity of hours. I also think about how many hours a week is somebody doing this. So you're racking a lot of hours of experience doing this exclusively. And you're just having more contact points with more breastfeeding problems. So I'm a big fan of the private practice lactation consultant or office-based IBCLC. And I think it's important to note you're different than a nurse practitioner in a pediatric office who also has her IBCLC.
Yes, I think that's important to talk about respectfully, because they don't have the time.
No. And if they're doing high school and sports physicals during the hours that you're doing lactation consults, they just aren't going to be the same type of experience. So know what you're getting and be an informed consumer. And the same goes for childbirth education. With any hospital-based curriculum for breastfeeding or childbirth ed, they have certain policies they have to follow. So you're going to get a different training or information session than you would from a doula doing a private childbirth class, or a lactation consultant who can share all of her wisdom, all the big points that you wanted to without those restrictions.
Yeah, I think it's true too. The other part of that is, I said, I worked in both worlds, and I want parents to know. Somebody said this to me the other day, know about your birthing hospital first. I talked to a doula who said this to me, and it was just brilliant. Know where you want to deliver first, and then find a provider within that umbrella, because you can do all of this great kind of really reaffirming work, and I really want as a non-interventional birth as you'd like, and then you go into an institution that maybe doesn't support all of that, and there's a big clash. So I think it's important to kind of understand where you're having your baby and what they're going to allow.
Support. Well, there's a birthing culture at each hospital.
Right, exactly.
And I think there's, you get I tell clients sometimes, you get a bad haircut once and you're like, I'm never going back there. I'm gonna tell my 3 girlfriends steer clear from her highlights or whatever it might be. But
Bad
people will
highlights.
stay with an OBGYN with their most vulnerable parts, right? And sometimes it feels like they can't leave, or the power dynamic is disproportionate, which is a systemic issue, not a person issue. It's not the patient's fault,
Right.
but
True.
there's this built-in power dynamic. And so I also like to remind clients that not every amazing GYN is the right OB for you. And those specialties get lumped together, but they're very different care. Same
Sure.
geographic area of the body, but very different types of care.
Yes.
And I think that it's natural. I'm guessing that you probably know some OBs who love to catch babies, and then some who really like GYN surgery, or they like the 9 to 5 annual visits and how are the kids check-ins. Those are very different types of care, and the person who was the right GYN for the first 10 years of your adult life isn't necessarily the person you might want to birth with.
That's a wise statement. That's true.
We'll talk about clarifying what do you want in a birth, and are you going to get it where you're going right now. And I also think I don't funnel people to one specific provider, but I do like to share the positive relationships I have with some providers. There are some providers who acknowledge that the uterus attached to the woman you're serving also is connected to a brain and a whole person. Right. So there are some providers who are exceptional in partnering with mental health providers and caring for that whole person.
So if we're thinking about people listening today who really are concerned that they need mental health support through their pregnancy, preconception pregnancy, or postpartum, how do you, because we live in Connecticut, and I've said this before on the podcast, that we have such a great referral system, and I love the birth community here in our area, but maybe you don't know about the birth scene in Austin, Texas, or Topeka, Kansas. How are people going to find support, Catherine?
Postpartum Support International is absolutely the go-to.
Back to PSI, which I'll have my producer put some stuff about PSI on the visit.
In Connecticut, we have a local chapter which lists support groups around the state, which is really wonderful to narrow down your search. And internationally, PSI has a directory, www.psidirectory.com. Now, when people are looking for a therapist, sometimes the bottom of the barrel for a medical doctor is to say, look up on your insurance. A person who needs mental health support cannot filter through their massive insurance directory if they can even get one. That is not helpful. And then some people say, Google it, and you might get Psychology Today listings. And full transparency, I'm on Psychology Today because it's a common directory, but anybody can check pregnancy, prenatal, postpartum. There's no vetting process. And sometimes somebody's like, I gave birth once. That does not qualify you.
Does not make you a perinatal mental health therapist.
I've birthed a few people. Do not ask me to be your midwife, right? You want someone with qualifications, with actual training. So PSI directory has a requirement that you have to disclose what type of perinatal training you have. And typically people know about the PSI directory because they've attended their training. So you're much more likely to narrow down somebody in your area who actually has the appropriate qualifications to support you. The directory is international, as I said, and you can filter by country or state and then insurance to narrow it down.
That's nice.
And some questions you might ask when you're reaching out to a therapist could include, how do you support moms? Do you welcome babies into your practice if you're doing in-person care? Spoiler alert, they all should, because separating mom and baby unnecessarily is not useful for anybody. Do you collaborate with other providers? It's not uncommon for me to refer to lactation, to doulas, childbirth educators, to chiropractors to help reduce likelihood of breech and reduce discomfort. I have had multiple people over the years be told by a professional, you're going to have pubic symphysis pain. Someone can barely walk. It'll resolve when you have a baby. Well, no, there are other professionals who can help you not live in pain for the next 3 months. So I'll connect people to chiropractors, to naturopathic physicians, to acupuncturists, and we can tackle so many peripartum issues with that team approach, and we get mom feeling more like herself quicker.
Oh yeah.
My goal isn't for you to need me forever. It's to help you get well, feel well, know what tools you need to use, and then call me if you need me again.
Yeah.
And I want people to have those resources. It's not fair to ask women to find this all on their own at the most difficult time in their developmental stage of growing their family. And there are people out here who can help and who want to help.
And the other part too, again, a little bit of a silver lining is that there's so much virtual therapy happening now, right? Especially right now. So that in turn has opened up huge amounts of resources for people maybe who couldn't physically get to you or another provider before. So can you talk a little bit
I have a
about
lot of clients who,
Yeah.
I have so many people who are across the state right now, and also people who are able to keep going to therapy when they're back at work because of virtual offerings. Telehealth is covered by all insurances, including Medicaid right now in Connecticut, and that's not going away, even though some insurance companies would like to skimp on their coverage where they can.
Lactation claims right now, they're pushing back on lactation, which is terrible, but that's a whole nother.
I've seen pushback, but we're not giving up.
Good.
The therapists of the world are not going to let the insurance companies drive access to care.
Good.
I just won't have it. So typically most states require that you're licensed in the state where the client is located at the time of service. So I can serve anybody who is physically in Connecticut. And that means you could be in Springfield, Massachusetts and drive over the state line and sit in your car if you want to. They have to be located in Connecticut at the time of service. And there are some therapists who get licensed in multiple states, which also increases access. So I've had a lot of clients who are working from home, or they see me on a remote work day and they're able to take exactly 1 hour off, where their work computer's off to the side and they can see me. And that really has helped with adjusting to returning to work.
That's great.
You couldn't easily do that in a lot of workplaces prior to COVID. So that's a silver lining I'll take.
Take that, definitely.
And while I love having clients in my office and encouraging them to get up and get out of the house with the baby and build that confidence, I can travel with the baby, I can do this, I'd rather you see me at home than not see me. Absolutely. And sometimes moms also have what I call appointment fatigue. They're, doing chiropractic care and lactation consults to help baby learn to latch, or working on a latch and feeding issues, and they're doing extra weigh-ins at the pediatrician. And it's just a lot of appointments. And if I can make that easier without sacrificing counseling, all the better.
Right. So virtual can help in so many different ways to kind of decrease all of that. And you can sit home and you're cozy and make it work. Well, I loved talking to you. Thank you so much. I think the message that I want to make sure that people hear, and the reason I wanted you as my first guest all those months ago when I first started thinking about the happy nipple, was that you don't have to suffer. You don't have to be scared. You don't have to be whatever it is you are by yourself. You can get help, and you should get help. And if something is making you not be the best you can be, I think that's really important to reach out. It's really important. I know you can say so much more about this, but
I don't promise how, because it's different for every parent, but I do feel confident that with help, it will get better and we will figure it out. There's no reason you should have to do it alone.
Right.
And there are so many people who struggle. And I think a valuable distinction is that postpartum emotional complications are common, but not normal. That means they happen to a lot of people, but this is not as good as it gets.
Right.
And we can work together, and you deserve to enjoy motherhood and feel well, not feel like a shell of yourself, and find that balance.
Yeah, I want people to be happy. I want you to love to feed your baby, however that looks. I want you to be happy. And if you need some mental health counseling to get there, then get it. It's covered by lots of insurances. Make sure you find the right person. That's a whole nother discussion. But thank you so much for reaching out. I know that we have some good people, and you're kind of pulling together other resources in your own practice, and things are changing. So keep us abreast of that. How do people find you, Catherine? How would they reach you? My website is www.growingwellcounseling.com, or you can search the PSI directory, psidirectory.com. Yep. And that's a really great place to kind of shop around, because I am not going to be indirect about this. I'm not the counselor for everyone, and no one is, and nobody should try to be. Sure.
there are different personalities, different approaches, different backgrounds and training. And if I'm not the right fit, I try to help somebody find somebody who is. There are some amazing therapists in this field that I have the utmost respect for, but I don't get referrals from often for overflow because they're just not like me. The person who's looking for the older, nurturing, soft librarian volume person isn't going to click with me. They're going to be like, whoa, that's a lot, Catherine.
That's a lot.
I'm a little more high energy and I'm down to the point. And there are people who like really reflective therapy and want to dig deep into the childhood stuff. And I really try to take a solution focused and resourcing approach. So I want to think about the here and now, and we can label it and we can say, yep, that's from childhood. Now, what are we going to do right now going forward to get you feeling well as quickly as possible? And so if I don't feel like I'm a good fit, I need those relationships with other clinicians who have different styles so that I can say, I know who you need. You need her.
I know who I can send you to. Well, thank you for joining us today. I so appreciate it.
So much for having me.
Took the time. I know. And it has been fun. We could probably talk another hour, but you know how that goes. Yeah, I could do this forever and it's fun, but I'm glad you gave us some resources, some things to think about. This is a huge part of being pregnant, having a baby and nursing that I think gets kind of lost along the way sometimes. So I'm glad you're here for us.
And if you aren't necessarily looking for a therapist, but you have questions about perinatal mental health, I love to talk. I love to email. People can email me and ask brief questions, and I'm always happy to give them resources or support. Because you're really an important part of the work I do.
Are the best. Thank you so much, honey. Have a good Saturday. Go find your cozy. Take care. Bye.
Bye.